All right, good morning. So what we're going to do today is, given the poll and how close it was, instead of running through 2 questions, I thought today, why don't we run through 3 questions? And the way that we're going to run it today is I'll run through each question separately with the exams report and then concepts related to it. And then at the end of about 30 to 45 minutes after the presentation, what we'll do is we'll actually go and answer those 3 questions in a row. So that's the challenge for today. So the first question was from August, September 2014, question 9. What lower limit of SpO2 would you accept in an ASA1 young male under general anesthesia? Explain your reasons for choosing this value. Looking at the exams report, to construct a good answer, this question required the candidate to integrate a number of the syllabus areas. Candidates should begin with defining SpO2 and establishing a normal range. The relationships between SpO2, SaO2, so arterial saturations versus pulse oximetry, and then the partial pressure of arterial oxygen, oxygen content, and oxygen delivery should be explained, as well as the factors that affect these relationships. All proposed limits of acceptable pulse oximetry saturations gain marks, so long as the reasoning was valid. The pulse oximetry saturations that correlated with hypoxemia was often proposed. Assorted definitions of hypoxemia were offered. The deleterious effects of borderline hypoxemia were often not mentioned or overstated. Expected acute compensatory mechanisms were rarely mentioned. Duration of hypoxemia should be considered when setting a lower acceptable limit. Terms such as physiological reserve and acute compromise should not be used without adequate explanation. This is a very complex examiner's report because there's a lot to unpackage here. The summary of the exams report is that we need to define the pulse oximetry saturations with a normal range. We need to explain the relationship between pulse oximetry, arterial saturations, partial pressure of oxygen, oxygen content, and oxygen delivery. This is the challenge here, is to explain this relationship succinctly. So that's what we're going to do. The next thing that we need to do is correlate pulse oximetry saturations with hypoxemia and define hypoxemia. Then we need to describe the acute compensatory mechanisms, which is analogous to physiological reserve, and describe the deleterious effects of hypoxemia in relation to severity and duration. Because of the complexity of what the examiner wants and the time limitation of 10 minutes, this question is actually very, very challenging. So the next sort of slides will try to encapsulate the essence of what the examiner wants and hopefully be able to answer each of these components. With the definitions, so pulse oximetry saturations, so SpO2, uses pulse oximetry to measure functional oxygen saturation. What do I mean by functional oxygen saturation? It means you're only including the hemoglobin that can participate in oxygen carriage. So that's oxyhemoglobin and deoxyhemoglobin. So the way that it's calculated is that it's oxyhemoglobin divided by oxy plus deoxyhemoglobin. Now, arterial saturations uses co-oximetry through an arterial blood gas, which measures fractional oxygen saturation. What do I mean by that? So the denominator is total hemoglobin. So not only does it include oxy and deoxy, but it includes other types of hemoglobins like sulfur hemoglobins, met hemoglobin. And then the formula is oxyhemoglobin divided by total hemoglobin. And the agreement is pretty close because the amount of sulfur hemoglobins, methemoglobins is very small. So the agreement is often quoted at plus minus 2 to 3%, okay? Now, the relationship between oxygen delivery and oxygen content is through this formula here. It's the oxygen flux equation. So oxygen delivery equals cardiac output multiplied by oxygen content. The next thing that we need to do is that we need to create a relationship between the arterial saturations, content, and partial pressure of oxygen. So in this slide here, what we've done is we have described the relationship between SpO2 and SaO2 and arterial saturations. And we've also described that relationship in terms of oxygen content and oxygen delivery. What we need to do next is that we need to define the relationship between arterial saturations and oxygen content versus the partial pressure of oxygen. And you can see, hopefully, that I've written this down, that it's giving you a clue in terms of how we do it. So to do that, we use the oxygen hemoglobin dissociation curve. And you can see that the way to do it is that saturations and content are on the y-axis. And you can draw them on one side, but this diagram is from West, where they have saturations on here and oxygen content or oxygen concentration over on this y-axis here. And what you have on the x-axis is your partial pressure of oxygen, but the curve is a sigmoid curve, and the relationship between these two is exactly the same. So sometimes you will see in certain diagrams, instead of seeing saturations on the y-axis, you'll actually see content or concentration on here, okay? And that's how we're going to describe those relationships. Now we need to find what hypoxemia is. And at its simplicity, in terms of its simplicity, it is just decreased partial pressure of oxygen in blood, specifically a partial pressure of oxygen less than 60 millimeters of mercury or saturations less than 91%. What are the causes of hypoxemia? This is how I want you guys to divide it. So the causes of a hypoxemia can decrease the alveolar oxygen where the AA gradient is normal. And the causes of that are low FiO2 or hypoventilation, which is caused by alveolar dead space, where the VQ ratio is infinity. The other cause of hypoxemia is how it decreases arterial oxygen, where the AA gradient is abnormal. And those causes are VQ mismatch, where the VQ is everything between infinity and 0, but doesn't include infinity, 1, or 0. Shunt is where VQ equals 0. And then lastly, diffusion impairment. You'll see in a lot of textbooks that they will just list this as the causes of hypoxemia. So the cause of hypoxemia in textbooks will be listed as low FiO2, hypoventilation, VQ mismatch, shunt, and diffusion impairment. But the way that I want you to think about this is that the first two, so FiO2 and hypoventilation, decrease your alveolar oxygen, but your AA gradient is normal. And all these causes here decreases your arterial oxygen, where your AA gradient is abnormal. This is probably best shown graphically using the oxygen cascade. You can see here that as we go from dry air to humidified air to alveolar PO2, what causes the drop from 160 to 100 is everything in here, which is your alveolar gas equation. And And the causes of the drop in alveolar O2 from the alveolar gas equation is anything that reduces your FiO2 and hypoventilation, which increases your alveolar CO2. And you can see that what it does is, if you think about this, you've got it at 100, but you can actually still maintain the same AA gradient. Okay, so the alveolar arterial gradient can be the same. And what you have is any pathologies in FiO2 or hypoventilation, it pushes down your alveolar O2. But your arterial O2 can still be the same. And so that is why low FiO2 and hypoventilation lower your alveolar O2, but your AA gradient remains the same. Now, conversely, look at these causes here. So these are the causes that drop from alveolar O2 to arterial O2. So these are diffusion impairment, VQ mismatch, and shunt. And these are the causes where you've got an increased AA gradient. So from here, this is your alveolar O2. All these three causes here will push this down here further. Okay. So I hope that's a light bulb moment for you guys here. Now, looking at the alveolar gas equation, so the alveolar O2 equals the fraction inspired of oxygen multiplied by the difference between barometric pressure minus saturated water vapor pressure. And apologies, there should be a P in front of here, minus the alveolar partial pressure of CO2 divided by your respiratory quotient. And reading off the formula here, the causes of hypoxemia, or the cause of a drop in alveolar O2, is anything that decreases FiO2, anything that decreases your barometric pressure, or anything that increases alveolar O2. Now, I always get asked this, or get told this, is that a high alveolar CO2 is a cause of hypoxemia. That is partly true. So yes, a higher alveolar CO2 will reduce the concentration of alveolar oxygen. But know this, the higher alveolar CO2 is the result of hypoventilation. In other words, alveolar CO2 is an indirect cause of hypoxemia, where the direct cause is hypoventilation. So when you look at textbooks and you look at the causes of hypoxemia, they will not list a high alveolar CO2, but they will list hypoventilation. So hypoventilation is the direct cause, and indirectly from hypoventilation, it increases your alveolar CO2, which then leads to hypoxemia. Let me explain this through this diagram here. And I will touch this up for next week's tutorial. But I've just drawn this. Overnight to sort of illustrate this concept here. So you've got normal alveolus here. So normal, and you've got your mixed venous blood. So your mixed venous blood has a partial pressure of oxygen of 40 and a partial pressure of CO2. Sorry, there should be a 2 here, of 45. And that's the same on this side here. So 40 and 45. And what happens is that the mixed venous blood comes through here. It equilibrates with the alveolus. Okay, this is in normal states. And what happens is that you get in arterial pulmonary blood or arterial blood, you get a PaO2 of 100 and PaCO2 of 40. But this is what happens when you have, hypothetically, an obstruction here. So now what you've created is alveolar dead space. So in the alveolus, which does not participate in gas exchange, your alveolar oxygen is 150 millimeters of mercury and your alveolar CO2 is 0. The problem arises is that the blood that was meant to be going through here can't go through here anymore. So what it does is it has to divert itself towards this side. And so now this alveolus here has double the perfusion. And because it's got double the perfusion, it's got double the amount of carbon dioxide. And given the time that it has to go, pass through the alveolus and participate in gas exchange, that is not enough to allow that CO2 to be excreted. So what happens is that there's a rise in your mixed venous CO2 to, let's say, 65, okay? And in the alveolus, it's got a PaCO2 of 60. And because it's got a PaCO2 of 60, through the alveolar gas equation, it becomes an alveolar oxygen of 75, because having that CO2 increase itself in terms of the concentration will reduce the alveolar oxygen. And then you get the gas exchange. And ultimately what happens is that you get a PaCO2 of 60 and you get that drop in your arterial oxygen. So we're not yet causing hypoxemia, because remember, hypoxemia is less than 60 millimeters of mercury, but you can see the concept of how alveolar dead space indirectly increases your alveolar CO2. And by increasing your alveolar CO2, it reduces your alveolar oxygen, which is how hypoventilation and alveolar dead space cause you to be hypoxemic. These are the responses to oxygen delivery to vital organs in a healthy patient. And these occur within hours to days. So there's hypoxic pulmonary vasoconstriction to improve VQ matching. There's activation of your carotid chemoreceptors in your carotid bodies. So these cause an increase in your ventilatory drive, although note, it is depressed during anesthesia. The other thing that the carotid bodies do is that it increases your sympathetic activation, which increases your cardiac output via increased heart rate and increased stroke volume via an increase in venous return. What is the goal? So the goal is to avoid significant hypoxemia. And when the significant hypoxemia occur, well, it's related to your oxygen delivery. So this is the graph from nuns, which shows that normal oxygen delivery is about 1,000 mils per minute, and your normal oxygen extraction ratio is approximately 25%. And what you can see here is that when your oxygen delivery drops by about 40 to 50%, lactic acidosis starts occurring. So that's when your overall extraction ratio drops between 40 to 50%. So this is overall, because remember, the heart has a very high extraction ratio, and the heart also has that ability to increase it to about 75%. Okay. And, following on from that, the myocardium with its high extraction ratio of more than 50% can only increase to 75%. So it will have limited ability to compensate once your saturations drop to less than 60% for more than 5 minutes. And this is in a healthy individual. It is going to be higher in someone with pathology. And the way that I've done the calculations for how much drop in PO2 is safe is that, remember that oxygen delivery equals cardiac output multiplied by oxygen content, where oxygen content is a function of hemoglobin, saturations, and the partial pressure of oxygen. So I'm assuming that your hemoglobin is the same, and I'm assuming your cardiac output's the same. And the only thing that's changing is the saturations and the partial pressure of oxygen. Okay, and that's how, when you do the calculations, when you reach a saturations less than 60% and everything else remains equal, that's when your oxygen delivery will drop by more than 40%. And that's when you start increasing lactic acidosis. So those are the key concepts for question 1. We're going to go through the next question, which is discuss the factors that affect oxygen transport from the alveoli to the tissues. And this was in February, March 2018. Going through the exams report, 5 topics could earn marks if correctly described and discussed: the oxygen cascade diagram, the alveolar gas equation, fixed laws of diffusion, oxygen flux equation, and the hemoglobin oxygen dissociation curve. So most candidates mentioned fixed law and component factors affecting diffusion. There was a large emphasis on time versus perfusion, limiting of diffusion, and little discussion of the partial pressure gradient driving diffusion. Relatively few candidates described the alveolar gas equation. Most candidates described the oxygen flux equation and the components of oxygen content of blood. Around half discussed the hemoglobin oxygen dissociation curve and factors affecting unloading of oxygen in tissues. A small number of candidates correctly mentioned shunt, and I'm highlighting this in red, not because I think we should be avoiding this, but I actually think the examiner's report is incorrect. So this one here says several candidates incorrectly mentioned alveolar dead space as factors impacting alveolar to arterial partial pressure gradient. Now, it is correct to say that alveolar dead space doesn't change your AA gradient. But remember from the previous slides, alveolar dead space decreases your alveolar oxygen. Your AA gradient is still the same, but your alveolar oxygen is reduced. And by reducing your alveolar oxygen, it actually reduces the driving pressure. So this is why this statement here, I know what the examiner is hinting at, but it's not 100% correct. So just be aware, okay? No candidates discussed the role of oxygen consumption by mitochondria as the primary motive force for movement of oxygen. So a summary of the exam's report, the components that we need to add to our answer is that we need to add the oxygen cascade diagram. We need to have the alveolar gas equation. We need to talk about the fixed law of diffusion, not just for the alveolar capillary membrane, but also for when we talk about the arterial to capillary diffusion of oxygen in the tissues, okay? So we need to talk about the partial pressure gradient driving diffusion, as well as the concepts of perfusion limitation, and then the oxygen flux equation, and also mention the hemoglobin oxygen dissociation curve, whilst also in our answer, we need to add the concepts of shunt and oxygen consumption. There's a lot of concepts here to add to our answer. So the way to do this is to make sure that we know which ones that we can talk about briefly, okay, or succinctly. This is the oxygen cascade diagram. And remember the yellow box here are the causes of hypoxemia where your AA gradient is normal. And this orange box here are the causes of hypoxemia where your AA gradient is abnormal. The way that I think about this question is that there's 3 components to it. There's your transfer of oxygen from your alveolar to pulmonary capillary. And then we need to think about going from the pulmonary capillary to arterial blood. And that's where you get mixing. And you can bring in the concept of shunt here. as well as VQ mismatch. And thirdly, we need to talk about the transfer of oxygen from arterial blood to tissues. So going from the alveolus to the pulmonary capillary, the way that it's done is through passive diffusion via Fick's law, where the uptake of oxygen is proportional to the surface area divided by thickness, multiplied by the solubility divided by the square root of the molecular weight, multiplied by the partial pressure difference. And the partial pressure difference here is with your alveolar oxygen difference to your mixed venous oxygen difference. And this is where you add the alveolar gas equation here. Okay, so your alveolar oxygen here equals your fraction inspired of oxygen multiplied the difference between barometric pressure minus saturated vapor pressure minus the alveolar CO2 divided by your respiratory quotient. This, now talking about perfusion limitation, don't go too much into detail because there's so much things to discuss with this question. Okay, and the way that I would think about this is that oxygen needs to react with hemoglobin for it to be carried, and that is dependent on the capillary transit time as well as the amount of hemoglobin. And the amount of hemoglobin is dependent on the concentration of hemoglobin as well as the cardiac output. And that will determine how much hemoglobin per unit time is being delivered to the alveolus to carry out oxygen. And thirdly, the hemoglobin oxygen dissociation curve. And I would just have a very simple statement like this because there's just so many concepts to cover. And I think this just describes it quite succinctly, where there's increased uptake of oxygen with a right shift from decreased hydrogen ions. Sorry, that should be a left shift. Sorry, so apologies. There's an error there. If you guys can fix that. So there's increased uptake with a left shift from decreased hydrogen ions, decreased partial pressure of CO2, decreased temperature, and decreased 2,3-DPG. And that increases the uptake of oxygen in the lungs. Now, the second part is from going from pulmonary capillary to arterial blood. So this is where we talk about mixing. And the first component is VQ mismatch. I've given you this diagram here just to illustrate what I mean by mixing. So you've got mixed venous blood here, and it goes through different types of alveoli with all different types of VQ ratios. And ultimately, they all come back to the arterial blood where they all mix together to give you one final result. Okay, so this is how VQ mismatch dilutes your arterial oxygen saturation. And what dilutes it even more is shunt. So shunt is blood that passes from the right to left side of the heart without participating in gas exchange. And from this diagram here, you can see that the shunt here will mix with the pulmonary capillary blood, and so it will reduce your arterial oxygen in the end. And you'll see that these two components, VQ mismatch and shunt, will be included into the concept of venous admixture. And what venous admixture does is that it includes all this mixing here from VQ mismatch and translates that into a shunt fraction, because what it does is it sees what is the drop here and what is the mixing required to cause this drop, and it will calculate that as a shunt fraction. So that's what venous admixture is. Venous admixture is a virtual shunt. Know that it's a calculated shunt. It's not a pathological, sorry, it's not a pathology. The pathology is VQ mismatch and shunt. With oxygen delivery, so we know that oxygen delivery or oxygen flux equals your cardiac output multiplied by oxygen content, and this is the oxygen content here. So 1.34 multiplied by hemoglobin multiplied by saturations plus 0.03 multiplied by the partial pressure of oxygen. The other number that you'll often see is 0.003 times the partial pressure of oxygen. And you will see that when the units are mils per deciliter. Okay, so that is why you'll see two numbers in different textbooks. One is for 0.03 is for mils per liter, 0.003 is for mils per deciliter. The oxygen transfer from arterial blood to tissues again occurs via passive diffusion via Fick's law. So you can repeat the formula again, but the difference is that the pressure gradient is due to the arterial oxygen difference minus the mitochondrial oxygen. And where the mitochondrial oxygen partial pressure is the primary motive force for the movement of oxygen, and the normal is between 1 to 5 millimeters of mercury. And adding this in will be able to answer the examiner's report, where they wanted you to describe mitochondrial PO2 as the primary motive force. The second thing that determines transfer of oxygen from arterial blood to tissues is the hemoglobin oxygen dissociation curve. So increased release of oxygen with increased hydrogen ions, increased partial pressure of CO2, temperature, and 2,3 dPg. And this one here, this one causes the right shift. Okay, so there's a right shift here. Now, thirdly, this is our last one that we need to cover. So the last one is describe the respiratory responses to hypoxemia in both the awake and anesthetized patient. And this was asked on the last paper in 2021, as well as in February, March 2018. The examiner's report in 2021 was a lot more succinct. So to pass the question, candidates were expected to define hypoxemia, outline the components of the associated physiological control system. A brief discussion of the sensors, integrators, and effectors was considered sufficient. Appreciate the relationship between respiratory drive or minute ventilation and partial pressure of oxygen. Outline hypoxic pulmonary vasoconstriction, and address some of the effects of anesthesia upon these responses. Common errors included confusion between carotid bodies and carotid sinuses. So the carotid sinus are where the baroreceptors are, and the carotid bodies are where the chemoreceptors are. And we'll focus primarily on the carotid bodies. No credit was awarded for discussion of cardiovascular responses, nor for describing the response to hypercapnia, other than its effect on the response to hypoxemia. Simply repeating information already displayed clearly in graphical form attracted no additional credit. And I think this summary of the examiner's report is pretty much all we need to do. So these 5 things. So we need to define hypoxemia. We need to outline the components of the physiological control system. In other words, the control of breathing. We need to describe the relationship between minute ventilation and arterial oxygen, outline hypoxic pulmonary vasoconstriction, and describe the effects of anesthesia upon these responses. This is a summary from West, which I think succinctly describes how the control of breathing works. So you've got the central controller, where its output affects the effectors, which are the respiratory muscles, and you've got the sensors, which provide input to the central controller. Okay. This is the diagram from Nuns, which explains it in a lot more detail. So the pontine respiratory group acts as the coordinator of the various inputs from the hypothalamus and the cortex. And what it does with that is that it coordinates those responses and it feeds that into the central pattern generator. The pontine respiratory group was previously known as the apneustic and the pneumotaxic center. So those are terms you will see in WES. But in nuns, it's called the pontine respiratory group. Now, the pre-Botzinger complex in the medulla is the anatomical location of where the central pattern generator is. And also within the medulla, you've got the dorsal and ventral respiratory groups of neurons, which are responsible for inspiration and expiration. So hypoxemia, the sensors are your peripheral chemoreceptors, and your carotid bodies are more important than your aortic bodies. Blood flow is approximately 2 liters per 100 grams per minute. So you can see that there is a lot of blood flow for the carotid bodies, so much so that oxygen requirements can be met by dissolved portions only. In other words, the partial pressure of oxygen. And the AV PO2 difference is small. So know that the arteriovenous difference is so small because of the high blood flow to it, okay? And I want you to note this because this is a multiple choice question. Now, it's not affected by oxygen content as long as the partial pressure of oxygen is normal and cells are able to utilize oxygen. In other words, the carotid bodies are not affected by anemia, carboxyhemoglobin, or methemoglobin, okay? So it doesn't matter what happens to the hemoglobin as long as the partial pressure of oxygen is normal and the cells are able to utilize it. Why have I got this here? Because even though carboxyhemoglobin doesn't affect it, carbon monoxide binds to cytochrome oxidase and causes cytotoxic hypoxia. So when that happens, that is how the carotid bodies get activated as well. Okay, so even though it doesn't get activated by carboxyhemoglobin, the way that carbon monoxide activates the carotid bodies is by binding to cytochrome. It's cytochrome oxidase, and it doesn't allow the cells to utilize oxygen. So that's the way that carbon monoxide gets away around this mechanism. Now, the mechanism starts when the partial pressure of oxygen is less than 60 millimeters mercury. And the mechanism is that there's a reduction in potassium efflux via oxygen-sensitive potassium channels in type 1 glomerulus cells that causes depolarization, increasing calcium influx, increasing neurotransmitter release, primarily acetylcholine and ATP. In nuns, dopamine is considered inhibitory, and it's described as excitatory in GNOM. Just be aware of that. All right. And then finally, the way that the effector nerve is through the afferent nerve is through the glossopharyngeal nerve. So you get excitation of the glossopharyngeal nerve, which sends the signal back into the pontine respiratory group. It sends it back to the hypothalamus, which then sends it to the pontine respiratory group, which then affects the central pattern generator. This is the graph that you need to draw to describe the relationship between arterial oxygen and minute ventilation. So the observations here is that you can see that minute ventilation, so we got the PO2 of 60 here, that minute ventilation starts rising up when PO2 is less than 60. The other thing that you'll note is that there's a shift. So there's a shift up and right. And that happens when you have increased partial pressure of CO2, so hypercapnia, as well as exercise, okay? And the shift is not just a right shift, it's a shift up and a shift right. And conversely, there's a shift down and left, and that is caused by hypoxemia or reduction in the partial pressure of CO2. This is the same diagram from Ganong's, and this diagram here describes the influence of anesthetic on this oxygen minute ventilation response curve. And what you can see is that as you increase the MAC, the curve starts to flatten. So 0.1 MAC produces a 50 to 70% depression of the response to hypoxemia, and 1.1 MAC causes 100% depression of the response. Okay. All right, and look, I will talk as I go along, but I'm happy for you to choose whatever question you guys want to do first. All right, it is 30 minutes, so it is and you know, you don't need to listen to me. I'm just talking as I'm recording. All right, but you guys can determine how much you want to spend on one question and just move on to the next. All right, you guys ready? All right, let's go. So the first question is, what lower limit of saturations would I accept? So I've got my definition. And then what I'm going to do is I'm going to have also the causes of hypoxemia. And I'm going to talk about the compensation here. So with the first SpO2, using pulse oximetry measures functional oxygen saturation and estimates so I'll get myself my full screen. And estimates arterial oxygen saturation, which measures fractional O2 saturation plus minus 2%. The relationship between arterial saturations, O2 content, and partial pressure of oxygen can be described via the hemoglobin O2 association curve, where oxygen delivery equals cardiac output multiplied by oxygen content. Over here, so PaO2 0, 100, 20, 40, 60, 80, and then I've got my percentage of hemoglobin saturation. And what I'm going to do here, let's go to this side here, which will have oxygen content. So we have 100 here, we'll have, this is in mils per deciliter, so 20, 10, 0, 20, 50, and we will draw this curve like this. And with the causes of hypoxemia, means that I would accept a lower limit SpO2 of 93% to allow a buffer zone before hypoxemia. I'll quickly define it. SpO2 less than 91% or PaO2 less than 60 millimeters of mercury occurs. Potential causes include low FiO2, hypoventilation, VQ mismatch, shunt, and diffusion impairment. Oh, hi, Stephanie. I think you've just joined us. We're just having a go answering some questions, Stephanie. So we're doing the 3 questions to time.
Okay.
And then, yeah, have a go just answering some of the questions. We're doing the lower limit of saturations that you would accept. We're also doing the factors that affect oxygen transport from the alveolus to the tissues. And then lastly, we're also doing the respiratory response to hypoxemia.
Thank you.
So compensation is, let me say one, male should have the physiological reserve to compensate for hours to days. Responses to increase O2 delivery include hypoxic pulmonary vasoconstriction to improve VQ matching, activation of carotid body chemoreceptors, which increase your ventilation drive. However, it is depressed with anesthesia, and increase sympathetic drive, which increases your cardiac output. And you also get metabolic vasodilation of important regional circulations. So you increase your cerebral blood flow, increase your blood flow. And ultimately the goal is to avoid significant hypoxemia, where lactic acidosis occurs when oxygen delivery decreases by 40 to 50%. Myocardium, with its high extraction ratio of more than 50%, will have limited ability to compensate O2 sets less than 60% more. minutes. All right. So now we have a question 2. So question 2 is describe the factors that affect oxygen transport. So I'm going to draw the oxygen cascade. I'll take up the alveolar, capillary membrane. The pulmonary capillary blood to arterial blood. Arterial blood tissues. So the O2 cascade describes the transfer of oxygen from air to mitochondria, atmosphere, and 0 to 160, 150, 100, 99, 50, and 5. That's my PO2 in millimeters of mercury. So this is from O2 consumption, O2 delivery. This is from diffusion, payment, EQ, mismatch, shunt, and this whole bit here is my alveolar gas equation. It's a PaO2, PaO2. So to transfer occurs via passive diffusion via Fick's law, where the uptake of oxygen is proportional to the surface area divided by your thickness multiplied by your solubility divided by the square root of molecular weight multiplied by the driving pressure, which is your alveolar O2 minus your mixed venous O2. Therefore, decrease diffusion with histology that decreases surface area or increases thickness. Brackets there. 2 decreases driving pressure, where decrease in alveolar oxygen, or decrease in alveolar oxygen is from reduction in your FiO2, reduction in your barometric pressure, or an increase in alveolar CO2.
The other thing is that there's also reaction with hemoglobin, where there's decreased diffusion with increased capillary transit time and decrease amount of hemoglobin from reduction in your hemoglobin concentration and or reduction in cardiac output. There's also a increase uptake via a reduction in hydrogen ions, pressure of CO2, temp, and 2,3 dpg because of left shift to hemoglobin oxygen dissociation. Okay. When we talk about capillary blood to arterial blood, there is a reduction in oxygen content from VQ mismatch and shunt, diluting pulmonary capillary blood and decreasing the arterial oxygen. With arterial blood tissues, oxygen delivery equals cardiac output multiplied by oxygen content where O2 content equals 1.34 times your hemoglobin times your saturations plus 0.03 times the partial pressure of oxygen in mils per liter. And the oxygen transfer to tissues occurs via, again, passive diffusion via Fick's law, where uptake of oxygen is proportional to the surface area divided by the thickness multiplied by the solubility divided by the square root of molecular weight multiplied by the partial pressure, driving pressure, which is your arterial 2 minus the mitochondrial O2. Therefore, decrease diffusion with pathology again, with pathology that decreases surface area or increases thickness, and the partial pressure of oxygen in the mitochondria. Mitochondria is the primary motive force for the movement of O2. It's approximately 1 to 5. Then maybe some mercury. And finally, so this A, this B, finally HbO2 dissociation curve, where increase O2 release via increased concentration of hydrogen ions, CO2 temperature, and 2-3 dBg via right shift of HbO2 association curve. All right. So next question is, describe the respiratory responses to hypoxemia in both the awake and anesthetized patient. So our definition, we have our responses, and we should have our mechanism. So mechanism can be divided into sensor. Since I'm going to draw a diagram, should be enough space. Controller and effector, and two is we'll have the effect of anesthesia here. Okay. The definition is hypoxemia equals PaO2 less than 60 millimeters of mercury, saturations less than 91%. So awake responses to hypoxemia to increase the alveolar O2 is by 1, increasing minute ventilation, and 2, toxic pulmonary vasoconstriction, and anesthesia blunts these responses in a dose dependent manner. All right, so mechanism, sensor, activation of peripheral chemoreceptors in the carotid bodies starts when PaO2 is less than 60 millimeters of mercury, decreases potassium efflux via oxygen sensitive potassium channels on type 1 lung cells, depolarizes cell, increasing calcium influx, triggering neuron transmitter release, excitation of glossopharyngeal nerves, and synergistic activity with increased PaCO2. Draw the diagram here. So PaO2, 100, 0, and 50. And then after that, you've got minute ventilation, so 0 to 40, 10, 20. Normal minute ventilation is just above 10, and like I say, it's going to start increasing it from here. So that one here, and start increasing it. And then what we have is we have a shift up and right with increasing PaCO2 for exercise, and we have a shift down here, decrease PaCO2. So the controller of this mechanism, so increase afferent activity of glossopharyngeal nerves. Activates the pre-Watzinger complex in the medulla via the hypothalamus and pontine respiratory group. Okay. And the effector, so there's increase in efferent activity to inspiratory muscles, which are the diaphragm, diaphragmic nerves, external intercostals via intercostal nerves, transvertebral muscles, and then the result is increase in minute ventilation. And effective anesthesia. Okay, so draw the graph here. Here's via dose dependent manner, and you've got my PaO2, got my percentage of ventilation, and we have 0, so this is 100, this is 200. PaO2, which is 50, 100. So normally, this is 60s. This is what happens. With 0.1 MAC, you get a 50% depression of the response. And then at 1.1 MAC, so it's here. So this is 1.1 MAC, and this is 0.1 MAC. So here to here, and from here to here. All right, so last bit is hypoxic pulmonary vasoconstriction. improves VQ matching, volatiles more than 1 Mach, blunts this response, less than 1 Mach in animals, but not in humans. And propofol has minimal effect on toxic coronary vasoconstriction. 30 seconds, guys. All right, that is time. So when you look at the oxygen cascade diagram, you know, the numbers that I often put down on the y-axis, 160, 150, 100, 99, 50, and 5. In other words, to go from 160 to 150 is to do with your saturated water vapor pressure. Okay, does that make sense? So 160 is FiO2, and then after that, from 160 to 150 is through saturated vapor pressure, and then from 150 to 100 is due to your alveolar CO2 divided by your respiratory quotient. And therefore, that will give you the answer for the first two. So the first two answers of what causes hypoxemia is low FiO2 or hypoventilation. Don't say, I mean, people will say an increase in alveolar CO2, which is what I want to talk about, but it's hypoventilation. Okay.
Because hypoventilation leads to the increased alveolar CO2.
And then the way that I also want you to think about it is that these are the cause of hypoxemia where your AA gradient is normal. In other words, your alveolar to arterial PO2 is normal, because what this does is, what happens is that when you reduce your FiO2 or you hypoventilate where your alveolar CO2 increases, it pushes your alveolar PO2 down. All right, but your arterial PO2 can still be the same. So in other words, that's why it still has a normal AA gradient. Does that make sense?
Okay. Yeah.
Yeah. So in other words, this line here, which is what your alveolar PO2 is affected by FiO2 or barometric pressure as well, and also your alveolar CO2, which is representative of ventilation status. And anything that changes this will push your alveolar PO2 down. All right. And when you push it down,
you're moving the yellow box.
Okay.
You're moving the yellow box.
Moving the yellow box, correct. That's right. Yeah. You're moving rather you're expanding the yellow box. You're expanding the yellow box. Okay. And therefore, that's the cause of hypoxemia with a normal AA gradient.
Okay.
This orange box here is what causes an increase in your AA gradient. So you've got your alveolar PO2 of 100. Because of these pathologies here, such as diffusion impairment, VQ mismatch, and shunt, this is what pushes this one down, okay? And therefore, diffusion impairment, VQ mismatch, and shunt are the cause of hypoxemia with an increased AA gradient.
Okay.
Yeah?
Oh, yeah.
Yes, makes sense? Okay, good. Yeah. I've got a light bulb moment. All right, great.